Um, Here is a case of a patient, Mrs. XYZ, who is of age 35 years, hailing from Kengeri. She works as a garments factory employee and she has studied up to 10th standard. She belongs to the lower middle class according to the modified Kuppuswamy classification. Her LMP is 2nd March 2022 and her EDD is 9th December 2022. Period of gestation 26 weeks. Obstetric score G2P1L1. Her husband details are her husband is Mr. ABC, who is a 37-year-old mechanic who has studied up to 7th standard and he is O positive. Obstetric history, married life 10 years. They have a non-consanguineous marriage. Obstetric score G2P1L1. She has a previous she has a child, her first child, full-term normal vaginal delivery at Rajarajeshwari Medical College. He was a male child of 8 years old, fully vaccinated according to the schedule. Birth weight of the child was 3 kgs. The child is alive and healthy. History of presenting pregnancy.
Okay, Nandini, first I'll stop you here. First of all, the way the pattern of your presentation, the past obstetric history would come after your history of presenting pregnancy. And before everything, what is the chief complaint? Why is she admitted?
Ma'am, there was no chief complaint that she's not admitted also. This was a
case. You just took a history from the OPD.
Yes, ma'am, OPD history.
Okay, so even when she comes in the OPD, how would you start? So you've started by giving her identification details, her LMP, her EDD, her obstetric score. What would be the next thing you would tell me? If she has no chief complaint, what would be the next thing?
History of present pregnancy.
Before that, I need to know what is her period of gestation, or how many months of amenorrhea is she presenting with when you today, when you've taken the history, what is the period of amenorrhea, or in months of pregnancy the patient will tell you, and you can tell me the period of gestation in weeks as you calculated. That should come right in the beginning along with the LMP and the EDD. Okay, so you mentioned, all right, 26 weeks. I didn't see this. Sorry, my mistake. Yeah.
No problem.
Okay. Yeah, 26 weeks. Okay, so if the patient had a chief complaint, if you had taken the history of an admitted patient, you would mention the chief complaint and the history of presenting complaint in the beginning, and then move on to the history of presenting pregnancy. But as you said, there is no chief complaint, so we'll directly move on to the history of presenting pregnancy. Tell me.
Okay, first trimester history. This is a case of spontaneous conception. Pregnancy was confirmed after 2 months of missed periods by a urine pregnancy test. She is a booked case at BGSGIMS. Folic acid tablets are taken. Her first dose of tetanus vaccine was given. Transvaginal scan was performed, and a twin gestation corresponding to the gestational age was confirmed. Total number of ANC visits in the first trimester is 3. There's no history of excessive vomiting, fever with rashes, burning menstruation, spotting or bleeding PV, pain abdomen, exposure to radiation or any drug intake.
Okay. Okay, so she is a twin pregnancy which was diagnosed in the first trimester itself. So are there any risk factors in her for twin pregnancy?
Yes, ma'am. Both hereditary, both her, there's maternal and paternal history of twinning.
Okay, so you haven't come to that yet, but otherwise anything else in her till now in her history which struck you that she is high risk of multiple pregnancy?
No, ma'am. She had spontaneous conception. No history of any drug intake. Like there was no.
So that's important. You have to ask history of any ovulation, induction, or infertility treatment. Okay, yes. What else? Something there. I did see something which I found a bit, which is a risk factor. What is it?
Her age.
Yes, very good. Her age. Why is age a risk factor for multiple pregnancy?
Ma'am, after, I'm not sure, but like the higher the age, it is an increased risk factor.
Yes, it is higher the age, but why higher the age?
I'm not sure, ma'am. Higher age and increased parity after 5 is also.
So higher age would lead to higher FSH levels. Okay, higher FSH levels can cause multiple ovulation to happen. Okay, or multiple follicles to develop because of the high FSH. Okay, so there have been found to be genetic populations, especially I think Nigeria is one population which has a higher incidence of twin pregnancy. There they found that the FSH levels in those women are on the higher side. So whenever FSH is high, there could be more than one follicle recruited, and hence the incidence of twin pregnancy increases. So you said ovulation induction is a risk factor for, or infertility treatment is a risk factor for twin pregnancy. So which type of twins would you found, if I say this woman had taken, say, clomiphene citrate for ovulation induction and then she conceived. So which type of twinning would be at a higher incidence?
I'm not sure, but my guess is that since there'll be multiple ova released, would it be zygotic pregnancy?
Which one?
Will it be dizygotic?
Yes, dizygotic. So with infertility treatment, whether it is ovulation induction or even IVF, the incidence of dizygotic twins increases. Okay, monozygotic, the incidence of monozygotic twinning. What is dizygotic or what is monozygotic? Can you explain?
Yes, ma'am. In dizygotic twinning, there are two ova that are released by two distinct grafted follicles from the same or separate ovaries, but they're released in the same ovarian cycle and they are fertilized by two separate sperms. But in monozygotic pregnancy, there is a single ova that is fertilized by a single sperm, and based on the division of the zygote in different, like it may divide in different time limits and that time periods, and that will give
right, correct. So with increasing IVF treatments and artificial reproductive techniques, the incidence of dizygotic twins has increased. The incidence of monozygotic twinning remains the same. Okay, yes. And you're right. Depending on when the monozygotic, the zygote splits, different types of twinning happens, which we will come to. Okay, so continue your history.
Second trimester history. Quickening was felt at 5 months of gestation. Anomaly scan was done and found to be normal. Iron and calcium supplements were taken. Second dose of tetanus vaccine was taken. There was no history of fever with rashes, burning, micturition, bleeding per vagina, pedal edema that doesn't subside with rest, headache, blurring of vision, or any drug intake or radiation exposure. A number of ENC visits in the second trimester were 3.
Okay. So what have you missed? Anything else you've missed in the second trimester?
Second trimester, ma'am, anomaly scan, NT scan.
What else is done in the second trimester? You've asked history of pedal edema, that is pointing towards preeclampsia, headache, blurring of vision. But what else is done in the second trimester? Routinely in all ANC, in all antenatal women.
In all?
In all antenatal women, what else is done in the second trimester? What else should you ask for?
At 24 weeks, we repeat OGT.
Yeah, we don't repeat. Prashant is right. At 24 weeks, 24 to 28 weeks, we do a OGTT. So that's very important to ask. Okay, because twin pregnancy is a high-risk pregnancy. Yeah. So, okay. So, and she's 35 years old. So the chance of her having GTM is increased. So she has two risk factors, and she has her age, 35, she's elderly, and secondly, she has twin pregnancy. So what all complications? She say the lady asks you, doctor, am I a high risk pregnancy? And if yes, what are the risks? What all am I at risk of? What will you explain to her?
Ma'am, in the first trimester, there is risk for hyperemesis, gravidarum, anemia, and also preeclampsia.
Okay.
And then she could have and in other risk in first polyhydramnios in the first trimester.
What else? In the first trimester. Polyhydramnios. When do you say it's polyhydramnios?
Second trimester.
In the second or third trimester. What else?
So in the second trimester, there could be placenta previa or like placenta abruptio, and then polyhydramnios, and we have to divide the complications of fetal and maternal complications.
Yes. So whenever somebody asks you a question like this, when the examiner asks you, just think for a moment and always divide your answer. That way you will get the, you will answer it better and you can quickly in your mind classify and tell us all the complications. Always divide as fetal and maternal, or you can also divide as complications in the first trimester, second trimester, third trimester, intrapartum, postpartum. Okay, so now tell me, fetal complications, what are they?
Ma'am, but the first maternal, if other than this, that if we even warn the mother that she might feel an increased movement, she might perceive.
That's not a complication. That's not a complication.
Sorry.
Increased movement is actually a good thing. It's not a complication.
And she might also have more dyspnea, palpitation, shortness of breath towards the pregnancy, and
right.
also that there might be over distended abdomen, so she should not worry about that because she's a mother who's already had a previous pregnancy.
Okay, so these are normal complaints in pregnancy are exaggerated. But what about what are the complications that can happen?
Varicose hemorrhoids are also a complication during
These are again normal things in pregnancy which are exaggerated. What are the complications that she can have? Okay, Prashant is right. PPH, preterm labor. Okay, so again, divide your answer. So I asked you in the beginning, what are the fetal complications we're worried about? Let's start with that. Let's start one by one. What are the fetal complications?
Fetal complications. The first you could have IUD.
And divide fetal complications first trimester. What are the first trimester fetal complications she can have?
In the first trimester, there could be first trimester abortions.
Yes, so she's at increased risk of spontaneous abortion because she is.
Ma'am, her age is much higher. Ma'am? Ma'am? Am I audible? Ma'am? Can someone reply if it's me or ma'am? Ma'am, am I audible?
I lost connection. Okay, yeah. So tell me, first trimester, fetal complications, what else?
Ma'am, then there could be vanishing twin.
There could be vanishing twin. Good. What is vanishing twin?
Ma'am, in the first trimester, if there is intrauterine death, then there'll be resorption of the fetus.
Okay.
In beginning, when you did the transvaginal scan, there could have been like you could have diagnosed twin pregnancy, but towards the end, there could be only a single twin pregnancy.
Okay.
And then, other than that, there'll be congenital anomalies.
Yes, very good. Congenital anomalies and chromosomal anomalies. Both are increased. Good. Then,
especially in zygotic twins, and then also IUGR.
Yes, very good. IUGR of both the twins or IUGR of one twin. What is IUGR of one twin called?
Ma'am, selective IUGR or discordant growth.
Called discordant twins. Very good. And then you also have complications specific to twin pregnancy, which are
specific to monochorionic pregnancy.
Yes.
That would be twin to twin transfusion syndrome. Or in chorionic monoamniotic, there's a problem of cord entanglement that could lead to thrombosis and death.
Okay.
And selective IUGR.
Okay.
And then the twin reverse arterial perfusion.
Right. So these are the list of fetal complications. What else? You can also have a preterm
labor, premature.
You can go into preterm labor and you end up with a preterm neonate. Okay, so these are the fetal complications. Now tell me some maternal complications. Again, divide your answer. First trimester, second trimester, third trimester, postpartum, and intrapartum and postpartum.
In the during pregnancy, ma'am, like in the first trimester, like I said, there would be nausea, vomiting, anemia, and then there'd be placenta previa, placenta abrupta, preeclampsia.
Okay, antepartum hemorrhage. Yes, then.
And then she would have preeclampsia, antepartum hemorrhage, and then I'm kind of spacing out. Ma'am? Ma'am, am I audible? Ma'am, am I audible?
Yeah, sorry again. Yeah, again got disconnected. I'm sorry. There's some. So basically, yeah,
Because of the increase in there could even
yeah.
be
Now I can hear you.
there could even be GDM like we discussed.
Right. So basically, if you open your obstetric book, all the chapters of complications, everything is increased in incidence in twin preterm to APH to malpresentations to cord prolapse to prolonged labor, obstructed labor, higher incidence of cesarean sections, postpartum hemorrhage, everything. So you try and in a twin pregnancy. Every chapter is increased incidence in twin pregnancy. Okay, so that's how you should answer this question. Okay, I'm sorry I keep getting disconnected.
It's okay, ma'am. During labor, she would have intrapartum hemorrhage and also there'd be increased surgical interference.
I can't hear you.
Ma'am,
Yeah.
intrapartum
abruption.
Surgical interference.
Right. Then
Preterm labor, intrapartum hemorrhage, and then increased surgical interference, so that could lead to infection. And post,
yeah.
Nandini,
I am going on losing my connection.
Ma'am, are you fine now?
No, just give me a moment. Let me just change my connection. Just give me a moment. Yeah, okay. Now I'm back. Now it should be fine. Okay, so yeah, intrapartum, what all did you tell me?
Intrapartum, there'll be preterm labor, ma'am. So that could be premature rupture of membranes will be there.
Okay, good.
Then there'll be intrapartum hemorrhage.
Yes.
And increased operative interference because of
yes, very good.
This could lead to infections and other complications.
Okay.
Postpartum hemorrhage because of atony of the uterine muscle. And there'll be increased because it's a big placenta, separation will be delayed, and also increased uterine sinusoidal exposure because of the big placenta. So all this could lead to postpartum.
Right. So basically, all complications are increased in a multiple pregnancy. Okay, good. So that's what you need to explain to the patient. Okay, continue with your presentation.
Yes, ma'am. Ma'am, also during puerperam, also we have to warn her about infections and hemorrhage.
Right.
And also subinvolution because.
Right.
Then menstrual history. Menarche is attained at 13 years of age. Past cycles 28 to 30-day cycles. 3 to 4 pads were changed per day, and she had flow of 4 to 5 days. There's no history of passage of clots or dysmenorrhea. Last menstrual period 2nd March 2022. Expected delivery date 9th December 2022. Contraceptive history. There's no contraceptives used. Diet history. At this 24-hour recall method, at 8 a.m. she had dry fruits.
What is her total calorie intake and what is her total protein intake? Did you calculate that?
Ma'am, I didn't calculate that.
That's important because she's twin pregnancy, so her calorie requirement increases. Okay, so the diet history, you don't need to tell me all this. You need to calculate after taking a history, calculate and tell the deficit. That's important. Okay, if she has any deficit, that's important. Okay.
Yes, ma'am.
Okay, continue.
Past history, she's not a known case of diabetes, hypertension, tuberculosis, epilepsy. There's no history of surgeries or blood transfusions, and no known allergies. Family history. History of twins is present in both maternal and paternal side. No history of children born with chromosomal anomalies or birth defects. No history of bleeding disorders in the family.
Okay, so you said what is the incidence of twin pregnancy in general, in the general population?
Ma'am, the twin pregnancy, according to Helen's rule in India, twins is 1 in 80 pregnancies.
Okay.
Triplets is 1 in 80 square, and quadruplets is 1 in.
Right. Good. So if the mother is 1/twin, say the mother herself is a twin. Okay, you said history of twins in both maternal and paternal side. I don't know who is the how far in relation is the twin pregnancy. But suppose the mother herself is 1/twin. So what is the incidence of her to have a twin? She herself is a twin. You understood my question?
Since maternal history is more relevant for twin pregnancy, I think they're higher.
Yes, but how much higher? So she herself is a twin. What is the instance she will have a twin pregnancy?
I'm not sure.
Okay, so it's around 1 in 50. Okay, so 1 in 80 is the general incidence, but if she herself is one of a twin, then the incidence is around 1 in 50. Okay, yeah, and already you told me the risk factors already, so I think we can move on.
Personal history, mother follows a mixed diet, adequate appetite, adequate sleep, increased frequency of micturition, regular bowel habits, no history of any addictions.
Okay.
Summary, here is a 35-year-old lady with an obstetric score of G2P1L1 with 26 weeks of amenorrhea who came for a regular antenatal visit. Her scans reported twin pregnancy with no fetal anomalies. She's a booked case and has been immunized till date.
Okay, examination.
General physical examination. Due consent was taken. Here is a 35-year-old lady who is moderately built and nourished, and she is conscious, cooperative, and well-oriented to time in person. Her weight is 60. Her weight is 68 kgs, height 164 centimeters, BMI 26.5 kg per meter square.
Okay.
Stenosis, clubbing, lymphadenopathy, edema was absent. Breast, spine, and thyroid are normal.
Okay.
Vitals, pulse rate 70 beats per minute. Blood pressure 120/78 millimeters of mercury. Respiratory rate 14 cycles per minute. Temperature 98.6 degree Fahrenheit.
Okay.
Per abdomen inspection, longitudinally distended abdomen, flanks are not full, central and everted umbilicus, linea nigra and stria gravidarum is present. There are no scars, sinuses, or dilated veins that are seen.
Okay.
Palpation, no local rise in temperature or tenderness. Symphysis fundal height is 32 centimeters and a fundal height is 32 weeks. Fetal movements are well felt. Grips not done.
Okay.
Palpation, no distinct fetal heart sounds. There are two distinct fetal heart sounds with a silent area in between.
Okay. What else is important in the fetal heart? Silent area in between. Also, what else to say that they're distinct?
Two distinct.
That they're not from the same fetus.
I have to feel it in two separate areas and
what else?
the change in the fetal heart rate.
What should the difference between the two fetal heart rates be?
I'm not sure.
At least 10 beats per minute. The difference should be at least 10 beats per minute between the two fetal heart rates. Okay.
Okay. What do 10 beats?
Okay, what else?
A systemic examination, CVS, S1 and S2 sounds are heard, no murmurs. RS, bilateral normovascular breath sounds heard. CNS, no focal neurological deficits. Provisional diagnosis, a 35-year-old lady with an obstetric score of G2P1L1 of 26 weeks of twin gestation, not in labor.
Okay, so Prashant's asking what is the difference isn't there. So the difference is is sort of a confirmation that yes, there are two separate fetuses. If the difference is not there, you have to of course confirm that the two fetuses are there, that the two fetal hearts are seen separately on real-time ultrasound. Okay, so this just gives a sort of a confirmation clinically that the two fetuses are separate. If there's a silent area in between and if the difference is more than 10 beats per minute, you may not find the difference also. Maybe the fetal hearts are the same. It's not necessary that there's a difference. It just confirms your finding of in pregnancy. Of course, you have to confirm this by doing an ultrasound. Okay, Nandini, tell me a few things. Number one, you said she's a booked case and she had come for 3 ANCs in the first trimester, 3 ANCs in the second trimester. Could you just list the investigations that would have been done for her in the antenatal period because she was a booked patient?
Initially, for all the cases of pregnancy,
yeah, just tell me what all we would have done for her.
The first antenatal visit itself, we will do check for her blood sugar, do a DIPSI test, and then we'll
in the first trimester. Why will we do a DIPSI? When is a DIPSI test done?
Ma'am, in the first antenatal visit, like as a screening test to rule out any undiagnosed diabetes or
So to rule out undiagnosed diabetes, what do we do? You're talking about overt diabetes, pre-gestational diabetes, right? DIPSI is done for gestational diabetes. It is done between 24 to 28 weeks. But in the first trimester, yes, in a high-risk population like India, we do check for pre-gestational diabetes, but we don't do a DIPSI. What do we do? And what is a DIPSI test?
OGCT.
DIPSI is not OGCT. What is OGCT?
DIPSI is a test that is done irrespective of whether or not the patient has had food, and we give 75 grams of sugar, and then
Yes.
hours later we check her blood sugar.
Give 75 grams of glucose, not sugar. Okay, we give 75 grams of glucose, and we check her
blood glucose levels after 2 hours, ma'am.
Okay, so this is called a DIPSI. It is a 75-gram oral glucose tolerance test. It is not a glucose challenge test. Glucose challenge test is separate. Glucose tolerance test is separate. Okay, so DIPSI is basically a single step for both screening and diagnosis of gestational diabetes mellitus done between 24 to 28 weeks. Please remember that a GCT used to be done earlier, many years earlier when we were postgraduates, it used to be done, and that was a screening test. Only for those who are positive, we would further do a GTT. But DIPSI has made it a one-step screening plus diagnostic. But this is for GDM. So in the first trimester, what do we do?
In the first trimester, we rule out HIV, HPS, AG.
No, for sugar, for pre-gestational diabetes, what do we do?
Ma'am, we can do oral glucose tolerance test.
We've done that, man. That we do that in the 6th month. What do we do in the first trimester?
A challenge test, oral glucose challenge test.
No, so see, whenever we talk about screening of diabetes in pregnancy, we do it twice. We do it in the first visit. That is for pre-gestational diabetes. That means the woman may already be diabetic, we don't know. And we do this in high-risk populations like ours, like the Asian population. And then we again repeat a screening at 24 to 28 weeks for gestational diabetes mellitus. So you're talking the GTT is for gestational diabetes mellitus. What do we do for screening in the first trimester for pre-gestational diabetes? Yes, Prashant is right. Prashant is saying HbA1c, correct. You can either do an HbA1c or you can do a fasting, or you can even do a random blood sugar. But you have to test for pre-gestational diabetes in high-risk populations like elderly, obese, family history, previous history of macrosomia, all that. Or in a high-risk population, ethnicity, if it is high-risk like ours. Okay. So you said, so diabetes is checked. For what else? You said HIV, what else? Nandini, are you there?
Ma'am, am I audible?
Now I can hear you. So you said, so diabetes we check for, what else do we check for?
Ma'am, first, the blood group is, we check the
Yeah, very good. So blood group and RH typing, good. What else?
Ma'am, and also we take HIV, HPSAG, VDRL
Yes.
test.
Yes.
And also we do a CBC to rule out anemia.
Yes, very good. We do a hemoglobin. What else?
And then, ma'am, it's not compulsory, but we can offer a trisomy screening.
Okay, we can offer her a trisomy screening. How do we offer her trisomy screening? What do we do?
I'm not sure, but rule out aneuploidy, I'm not sure how to offer her.
Okay, so anyone can answer that? How do we do a trisomy screening? Okay, we'll go to that again, but tell me again, what are the routine tests we do? You told me blood group, hemoglobin, HIV, HPS, VDRL. We've tested for sugars with an HbA1c or RBS or FPS. What else? You missed a few.
Urine analysis?
Yes, urine routine microscopy and urine culture has to be done in every trimester to look for asymptomatic bacteriuria. What else? One more important, which we do it in our country. We do a TSH. I don't know if you do it. It's not compulsory again, but the Indian Thyroid Society does recommend for all pregnant women a TSH has to be done in the first trimester of pregnancy. Okay, now Sneha is saying NT. Okay, so trisomy screening is done later on at 11 to 14 weeks. And this is basically, it's not called trisomy screening, it's called screening for aneuploidies, mainly Down syndrome. What are the other two syndromes we look for? Nandini, I think we've lost her. Anyone can tell us? We look for Down syndrome, that is trisomy 21. What are the other syndromes we look for in a aneuploidy screening? Okay, nobody. So we look for a trisomy 18 and trisomy 13. So these are the three syndromes we mainly look for. And how do we look for these? By doing what is called a double marker in the first trimester or a quadruple marker in the second trimester. Okay, and of course, looking at the nuchal translucency in the ultrasound between 11 to 14 weeks. So that is aneuploidy screening. Okay, and so these are the tests that should have been done. Now, the second question, Nandini, can you hear me?
Yes, ma'am.
Yeah, so the second question is in the what else? She's twin pregnancy. So how would we determine the type of twinning and when is the best time to determine the type of twinning in her? And why is it important?
Ma'am, the type of twinning is very important because that's how we manage the pregnancy. Because if she has a monozygotic pregnancy, then each type of twinning chorionicity, the delivery or the management of the pregnancy will be different, and
Okay.
then or even the complications for each type of pregnancy will be different.
Okay.
So we
Which type of twinning are we worried about most? In monozygotic, which is the one we're worried about?
Ma'am, in monochorionic, diamniotic, over there we have a twin-to-twin transfusion syndrome, so we are worried.
All monochorionic twin pregnancies we are worried about, where the placenta is shared, where they have a common placenta, right? And when do we, or how do we check this, or when is the right time to check for this?
Ma'am, we can do a transvaginal scan at 10 to 14 weeks, ma'am.
Okay, doesn't matter, the type of scanning doesn't matter, it could even be abdominal scan, but yes, around 10 to 14 weeks is when we check for the chorionicity. And how do we check for the chorionicity?
Ma'am, so, ma'am, is my video, is it clear, ma'am?
What?
Is my video clear now, ma'am?
Yeah, your video is clear, yeah.
So for chorionicity, what we do is, if it is diamniotic, dichorionic, then we have a twin peak sign or a lambda sign. So, and also we can make out that the thickness of the placental membranes in between both the fetus, and also the number of placental membranes between both the fetus. And if it is, in case it is a monochorionic, diamniotic, then there'll be a T sign.
Right. Okay, a reverse T sign, right? So because the membrane is very thin, it will be a reverse T sign, whereas in a thicker intertwin membrane, which is seen in dichorionic, diamniotic, the membrane is thicker, so you see a lambda sign or a twin peak sign. Correct.
And also, if it's a monochorionic, monoamniotic, then we can notice that there are no placental membranes in between both the fetuses.
If it's mono, there is no intertwin membrane. If it's mono, they are lying in the same amniotic cavity. So if it's a monoamniotic, monochorionic twinning, what are the additional risk factors she'll have?
Cord entanglement.
Right. So both the twins are in the same sac. So when they move around, the cord gets entangled. And because of that, when do we deliver such patients?
32 to 34 weeks for monochorionic.
Yeah. So as soon as fetal lung maturity is attained, by 34 weeks, we have to deliver monoamniotic, monochorionic pregnancies. Okay, so your patient, going back to your patient, she is 36 weeks. Do you know the type of twinning she has? Did you see her ultrasounds?
Yes, ma'am. She's a dizygotic pregnancy.
She's a we can never see dizygotic or monozygotic on the ultrasound. We can just say dichorionic, diamniotic.
Ma'am, why I said is because like our doctors, our professor was able to make out the sex and showed only us, not the patient. So that's
understood. Even if the sex is made out, you can be if they are the same sex. Okay, if they're different sex, agreed. Then you can say it is dizygotic. You're right. If they're different, if they're separate sex, then yes, but we're not allowed to see that. But if they're same sex, then they could be either again. Right. So your patient probably had different sex, right? So then you're sure it's dizygotic. So so diamniotic. Otherwise, your patient is basically diamniotic, dichorionic. So we're not that worried as if she were a monochorionic. So how would you further monitor this patient and how would you manage her antepartum period? And then we'll go to the intrapartum period.
Ma'am, initially we tell her that her diet and her nourishment should be much more. We have to explain to her that she needs an additional 300 kilocalories of dietary
Right.
intake, and even her protein intake must be higher. Then we should
Right.
also tell her about the importance of rest. We should tell her that by 24 weeks she should go into bed rest because that increases the uteroplacental circulation.
Bed rest. So she can't move at all. She can't get up. When you say bed rest, what does that mean? So the patient will completely lie down and be at rest. That's not right. What should you tell her? That she's at increased risk of what? Of preterm labor.
Labor, so then we
But
should
bed rest
decrease
will
the
not
physical activities.
help prevent preterm labor. Okay.
Yes.
So you need to advise her to rest. Okay, bed rest is not the right term. Avoid heavy work. Yes, go take a good nutritious diet. Come for regular antenatal checkups. Okay, take her iron prophylaxis properly. Okay, and when will you deliver her, this patient?
This patient we can wait until the when she goes into labor right now.
Okay, till
We
when can you wait? Can you wait till her EDD?
about 37 weeks at least.
Okay, so once she reaches term, that is 37 weeks, then you can plan delivery. So most of twin patients will go into labor by themselves, right?
Yes.
But usually they go into labor much before 40 weeks. They go into labor by 37, 38 weeks. They will go into labor. Okay, if they don't go into labor by 38 weeks, it is best to induce them because in twin pregnancy, maturity happens about 2 weeks earlier than a singleton. So if the EDD is at 40 weeks for a twin pregnancy, we take it as 38 weeks. Okay. So say this patient goes into labor at 37 weeks. What will you do?
Ma'am, if she goes into labor, then the first thing that we need to be sure of is the lie and presentation of both the children.
Very good. Very good. Right.
So if in case the lie of the first baby is a vertex position, then that is the indication for a vaginal delivery. But
Okay,
if both
good.
the fetuses, or even if both the fetus or the first fetus isn't in vertex position, that's an indication for cesarean section. So
Okay, so you said the most important thing is the presentation of the first fetus, right? If the first fetus is cephalic, we can allow her to have a vaginal delivery. But if the first twin is non-cephalic, it is an indication for a cesarean section. Can you tell me the other indications for cesarean section in twin pregnancy?
Yes, ma'am. If it is a if there's any interlocking of the twins, or if it is a monochorionic, monoamniotic, diamniotic
Right.
pregnancy with twin to twin transfusion syndrome, or if it is a monoamniotic pregnancy, also is an indication for
Okay. Okay. Right.
also cord entanglement.
Yes, cord entanglement, yes, but it's very difficult to diagnose. Okay, so first twin non-cephalic is an indication, monochorionic, monoamniotic is indication, twin-to-twin transfusion syndrome is an indication, discordant twins also is an indication, especially if the discordancy is severe,
Yes,
and also one more, rare variety of twins,
the conjoined
when
twins.
conjoined twins is also an indication. So this is apart from other obstetric indications. You may have placenta previa, you
Uh,
may have abruption. Apart from that, these are the other indications for cesarean section in a twin pregnancy. Okay, so the patient has gone into labor. First, when you've examined is cephalic, and you allow her to deliver. Say first one is cephalic, second is breech. Okay, this is the scenario. Okay, so you allow her to deliver. What are the precautions you'll take in the first stage of labor?
Yes, ma'am. We take an extended episiotomy.
The first stage of labor. First stage of labor.
Oh, during the first stage of labor, ma'am, we do not give a lot of analgesics, or we don't give general anesthesia. We limit the use of analgesics, and then yeah.
Precautions in the first stage of labor. She's 5 centimeters dilated. What are the precautions you'll take?
uh, the patient has to be in bed rest.
Yes, very good. So you won't allow her to ambulate too much, okay, because of the risk of
Premature the rupture of
membrane rupture and cord prolapse. Okay, so allow her to be in the resting position most of the time. Good. Number two.
We don't
always secure access with 2 large bore IV cannulas in the beginning only, because you may anticipate
bleed.
postpartum bleeding. So you should not be looking for an IV access at that time. So secure 2 large bore IV access lines in the beginning only, in the first stage of labor. And third thing, because you're anticipating PPH, what should you do?
Arrange for blood.
Yes. So these are the 3 things that are important in the first stage of labor. Avoid too much ambulation, IV access should be secured, and arrange blood. So, okay, so you've done these 3 things, and she's now in the second stage of labor. What precautions will you do in the second stage of labor?
Ma'am,
Now you said give a good episiotomy. Okay, what else?
She is in labor, like we give an extended episiotomy, and
Okay.
then after the cephalic, like after the vaginal delivery of the baby, we have to do a 2-cord clamping. And then we have to leave about 8 to 10 centimeters of the cord for any perfusion of the second twin. And also we do not give ergometry before the
Very
delivery.
good. So avoid, so you take the delivery as of any other fetus, a cephalic presentation, but important, don't give methyl ergometrin, okay, because that will, the uterus will contract over the second twin. What will you do? So first twin is out, you clamp the cord, you've avoided methyl ergometrin, what will you do next?
Ma'am, then next we again make sure about the lie. First we check the heart sound of
Very
the
good.
heart sound of
Very
the
good.
baby, the
Very
lie
good. Right.
If the second baby is also in vertex position, then we can go for vaginal delivery. But if the second baby is in breech position, and it depends on if the head is high or low. So if the head is high up, then we have to give a pudendal blot and think about an internal podalic version, and then go.
No, it's breech. The second is breech. Why do you want to do an internal podalic version?
Yeah, if it's sorry, ma'am, if it's breech, then we can do breech extraction. But if it's transverse,
breech extraction. Oh, wait. So if it's cephalic, allow the baby to deliver, right? If it is breech, what will you do? Why will you do a breech extraction? What is breech extraction?
Ma'am, breech extraction.
What are the 3 types of breech delivery?
I forgot.
You have spontaneous breech delivery, where you don't do anything, the baby comes out by itself. Second is assisted breech delivery, where you assist after the umbilicus, you assist the birth of the baby. You want to prevent the aftercoming head to get stuck. And the third is total breech extraction, where you put in your hand and pull the baby out. Okay, so you will do the second one, assisted breech delivery. Like any other breech, you will deliver as any other breech. Okay. The third scenario, which you said, is transverse lie. Babies in transverse lie. What will you do?
Then first we'll try for an external version itself. And then if that fails, then we'll go for internal podalic version and then go for breech extraction.
Yes, very good. Okay, so just to repeat, what she said is very right. So once the first baby is out, what do? We immediately take off our gloves and we examine, or per abdominal examination, see the lie and the presentation of the second twin. If it is a cephalic presentation, what do? We simply wait for the head to come down. Once the head has entered the pelvis, do an artificial rupture of membranes and deliver the second baby. We may have to augment with oxytocin, okay, because once the first baby is out, how much time do we have till the second baby?
Ma'am, 15 to 30 minutes, ma'am. It should not cross up beyond 30 minutes.
Yes, it should not cross beyond 30 minutes because of the risk of intrapartum as
uteroplacental insufficiency.
Yes. Why does uteroplacental insufficiency start happening?
Because the 30 minutes start to
the placenta starts separating. Okay, and the placenta starts separating. It is like an intrapartum abruption, and that will cause asphyxia of the second baby. So if it's cephalic presentation, do an ARM, starts into, let the baby deliver. If it is breech presentation, same thing, let the breech come down, do an ARM, deliver as assisted breech delivery. The problem comes in the third scenario, if it is a transverse lie. So as you said, very good, what will you do? First is you will try to externally do a version. So you can do either an external cephalic version. If the head is near the lower pole, try to bring the head down. If the breech is near the lower pole, try to bring the breech down. So do an ECV or an external podalic version. Whichever pole is nearer, try to bring it down. Basically, you want to bring the baby in longitudinal lie. And then do a cephalic delivery or a assisted breech delivery, whatever pole you bring down. Okay. But sometimes and many times that fails. If that fails, then what do? You take the patient to the OT immediately. Okay, because if you're going to do an internal polaric version with a total breech extraction, it has to be done under
general anesthesia.
General anesthesia. You need the uterus to be completely relaxed. It's not that easy. Putting your hand in, grabbing the foot of the baby, that is called a internal polaric version, and bringing the feet towards yourself and taking the baby out. It's not easy. It sounds very easy, but it's very difficult. I have never done this. I've seen it being done. I've never done it myself. Okay, so if the obstetrician is not skilled at doing a internal polaric version, the second option is you can take the patient to OT and do a cesarean section, right? So it's also an indication for a cesarean delivery. Or if that 30 minutes has crossed, you don't want to waste further time, so you can do a cesarean section. So these are the two options you have if it's a transverse lie. Okay, so that's very important. This question is very commonly asked. How do you manage intrapartum management of twin delivery? Postpartum management, what will you do?
Management, we have to give oxytocin, ma'am, almost up to 2 months.
So active, this word should come yourself, this sentence, active management of third stage of labor. Okay, if somebody asks you, how will you manage postpartum in any scenario? Always start by saying active management of third stage of labor. What is active management of third stage of labor? What are the components?
Oxytocin, controlled contraction, oxytocin.
Okay. Yeah.
And
so the first thing is delayed cord clamping. Okay. Oxytocin, delayed cord clamping, and controlled cord traction. Also, uterine massage. Yeah, uterine massage. So WHO has changed different components of AMTSL over the years, but the principle remains the same. Okay, delayed cord clamping is not to prevent PPH. Delayed cord clamping is to prevent fetal anemia, but it's added it to AMTSL so that whoever's conducting delivery remembers that this has to be done. But what actually prevents PPH is giving an oxytocin. The most common oxytocin is oxytocin. How much do you give oxytocin and which route?
IV oxytocin.
Okay, IV. If you have an IV access, IV can be given, or IM. How much?
Not sure.
10 units. This is very important. You have to know this. 10 units IV or IM. Okay, if an IV access is there, preferably IV, otherwise IM can be given. What are the other oxytocins that can be given for prevention?
Give ergometrin.
We can give ergometrin, we can give oxytocin. What else? What are the other oxytocins? Anybody who's listening in? Anyone else? What can we give? We can give carbitocin. What is carbitocin? It is a synthetic analog of oxytocin, okay, which is stable at room temperature. So this is a newer drug, carbitocin. So oxytocin, carbitocin, methyl ergometrin. We can also suppose the patient is in a rural area, rural setup. There's no IV access, there are no injections available. What can we give?
I'm not sure. Is it
a trained health worker is there? What can you give? There are no injections, no oxytocin in that setup, no cold chain being maintained. So what does the government give such centers? There are many rural areas, tribal areas where you don't have fridges. There's no cold chain. Patient goes in labor, she delivers. What do you give for prevention or treatment of PPH? Which drug can be given? Which drug can be given? Prostaglandin. Which prostaglandin can be given? PGE1, misoprostol. Okay, so PGE1, misoprostol, 600 microgram. One tablet is 400 micrograms. So 3 tablets can be given orally or sublingually or per rectally. Okay, so misoprostol, very important. You should know this. Misoprostol can be given. And the fifth drug which can be given as per the WHO is a combination of oxytocin plus methyl ergometrin. It's called as symptometrin. It's not available in India, but you should know because the WHO says 5 drugs for prevention of PPH. I'll repeat: oxytocin, carbitocin, methyl ergometrin, misoprostol, and symptometrin. Okay, so these 5 can be given. For treatment, what can we give? Suppose this patient has atonic PPH. She starts bleeding profusely like a tap. What will you do? How will you manage? And you examine, you find that the uterus is completely flabby. There is no contraction at all. What will you do? Placenta has delivered. Directly, we'll do a hysterectomy. You won't try anything else. So how do you manage PPH? How do you manage atonic postpartum hemorrhage? In any patient, forget this patient, atonic patient, you're in the labor room, patient starts bleeding profusely in front of you. You examine her, you find the uterus is atonic. What will you do?
Not sure, ma'am.
Okay, so Shankara is saying you will do B-Lynch. Okay, you're going in backward direction. You first said hysterectomy, then B-Lynch. These are the later things. Surgical management is later. First thing is medical management and mechanical management. So this is homework for all of you. How do you manage atonic PPH? Okay, so when you have multiple twin pregnancy ka case, always remember, because twin pregnancy has all sorts of complications that you can be asked on anything, and PPH is something which you should know. Okay. So medical management plus mechanical methods go hand in hand. Okay, medical management means all the oxytocic drugs you should know, and mechanical management means bimanual compression, aortic compression, putting an intrauterine balloon tamponade. And if these measures fail, then surgical management. And surgical management involves first doing devascularization, putting compression sutures, and last of all, hysterectomy. Okay, so these are the steps, and you should know how to manage atonic postpartum hemorrhage. Okay, so I think we'll end. It's 9 o'clock almost. Any question? Yeah, tell me.
How do they manage the patient? Like, if there is if there's death of one twin,
Okay,
after if it's the third term, if we find out that there's death of one twin and the other twin is not doing so well, so
right.
how to manage the death?
So fetal demise of one twin is again a complication that can happen, and it depends on several factors. Okay, number one, it depends on when the fetal demise has taken place. In the first trimester, it's called a vanishing twin. It usually has no effect on the fetus. Even the second trimester, it doesn't have much of an effect unless it is a monochorionic pregnancy. Okay, so monochorionic pregnancy, because of the vascular anastomosis, they could be, the second twin could get affected. Okay, but if it is a diamniotic, dichorionic twinning and fetal demise of one twin happens, you can continue the pregnancy till 34 weeks. That is till when fetal lung maturity is attained, and then you deliver that twin. But if there is any other obstetric risk factor, why did that twin die? Was there preeclampsia? Was there GDM? You have to expedite delivery. Then give steroids, attain fetal lung maturity, and then deliver if the other twin is not doing so well, as you said. If you have to do strict antepartum fetal monitoring of the surviving twin and deliver at 34 weeks or earlier if you feel that there is any fetal distress. Okay, but in monochorionic twins, you have to take a very urgent decision. In dichorionic, you can wait till 34 weeks. Okay?
Yes, ma'am. Ma'am, and before we end the session, can you just do like a small checklist of all the things that you would expect students to know in this?
Okay, right. So in twin pregnancy, you should know, number one, risk factors for twin pregnancy. Number two, you should know the complications, fetal, maternal, antepartum, intrapartum, postpartum complications of twin pregnancy. Number three, how to diagnose twin pregnancy on both clinical examination, which we didn't discuss, and on how to confirm twin pregnancy. You should know the types of twin pregnancy and how they are diagnosed, monozygotic, dizygotic, and the different types of chorionicity, amnionicity. Then you should know how to manage twin pregnancy, antepartum management, intrapartum management, postpartum management. So these are the 5 points you should know for twin pregnancy. All right.
Yes, ma'am.
Okay, so thank you very much. And PPH, read up on PPH. You presented very well, but you need to. So now that you're in final year, everything should come together. Okay,
yes.
So the case was on twin, that you still have to have an idea about everything else. Okay, because you can get quizzed on anything in the exam. All right.
Yes, ma'am.
Yeah. Okay. Thank you.
Thank you so much for the session. It was very an eye-opening session, and you really connected a lot of factors for us.
Thank you so much.
I'd also like to thank all the active participants of the presentation. They really helped me out a lot.
Yeah, Prashant and Shankara both were very active. Thank you.
Thank you. Thank you.
And Sneha also.
Have
Yeah.
a good night.
Okay, good night, everyone.